Pulmonology bursts, part 1. What will the pulse oximeter look like in a patient with carbon monoxide poisoning? Pulse ox in carbon monoxide poisoning will be falsely normal. And why is that? Well, it's because the carboxyhemoglobin, which is what's getting formed during carbon monoxide poisoning, looks exactly like oxyhemoglobin to the pulse oximeter. So the pulse ox cannot distinguish between carboxyhemoglobin and oxyhemoglobin, and therefore it's useless. And what will the pulse oximeter look like in a patient who has methemoglobinemia? So here in methemoglobinemia, the pulse ox will usually read somewhere around 85%, and that's inaccurate as well. Define Light's criteria in trying to distinguish a transudative versus an exudative pleural effusion. So according to Light's criteria, a pleural effusion is likely to be exudative if at least one of the following exists. Number 1, the ratio of pleural fluid protein to serum protein is greater than 0.5. Number 2, the ratio of pleural fluid LDH to serum LDH is greater than 0.6. And number 3, the pleural fluid LDH is greater than 0.66, the serum LDH upper limit of normal. I hate that last one. So again, Light's criteria, number 1, the ratio of pleural fluid protein to serum protein greater than 0.5. Number 2, pleural fluid LDH to serum LDH greater than 0.6. And number 3, the pleural fluid LDH is greater than 2/3 the LDH of the serum's upper limit of normal. I hate that last one. 3 cardinal symptoms of COPD exacerbation include these. This is pretty classic. COPD exacerbation, number 1, increased dyspnea. Number 2, increased sputum. And number 3, purulent sputum. 3 cardinal symptoms of COPD exacerbation, classic. How does reexpansion pulmonary edema occur? Reexpansion pulmonary edema. So this can sometimes occur if a lung has been in a state of collapse for a period of time, and it's often a few days at least, and then for some reason it rapidly reexpands. So from a state of collapse to rapid reexpansion, it's exactly what it sounds like. So if you just sound out the word, you can derive the definition. And what causes these? Well, they're usually iatrogenic. So maybe a recent large volume thoracentesis, or a pneumothorax, or a recent decortication. The removal of endobronchial obstruction, that could do it. Something of that matter. So it's basically a negative pressure pulmonary edema. And what's the prognosis for a patient who develops a reexpansion pulmonary edema? Well, it's something to worry about, something we should try to prevent. It's bad. So mortality of 10 up to 15%. Yup. Parapneumonic effusions, which are pleural effusions that result from pneumonias, lung abscesses, or bronchiectasis, are classified by 3 types. Can you name those? What are the 3 types of parapneumonic effusions? Number 1, an uncomplicated effusion. Number 2, a complicated effusion. And number 3, an empyema, which must be a very complicated effusion. And usually empyemas have their own sac around them. So number 1, uncomplicated effusion. You treat that with what? Antibiotics. Antibiotics only for uncomplicated effusion. Number 2, complicated effusions. How do you treat those? Chest tube drainage, so thoracostomy. And number 3, the big ol' empyema. How do you treat those? So this may involve decortication if bad enough, along with antibiotics and tube thoracostomy. Okay, so there are 3 types of parapneumonic effusions: uncomplicated, complicated, and empyema. Uncomplicated effusions generally respond well to appropriate antibiotic treatment. So the criteria for a complicated parapneumonic effusion include the presence of pus or a gram-stain positive pleural fluid or a pleural fluid pH less than 7. And appropriate management for complicated includes chest tube drainage, which is a tube thoracostomy. And treatment of empyemas include antibiotics, complete pleural fluid drainage, and reexpansion of the lung. And occasionally for the empyema, you're going to want to use, or you're going to want to go to decortication. Okay, so I know this is all complicated, and I apologize about that. I'm not even going to get into the rest of this stuff because it gets crazy. And I'm talking about diagnostic techniques. So there's plain film chest x-ray, there's CT, and there's ultrasound. The interesting thing about ultrasound is an empyema is usually isoechogenic with the liver. And that's all. We're not going to go into any more detail. True or false? Theophylline, montelukast, and salmeterol should be considered in addition to IV methylprednisolone in the treatment of acute asthma. So we're talking about the treatment of acute asthma. Do you add theophylline, montelukast, and salmeterol to IV methylprednisolone? Heck no. So theophylline, montelukast, and salmeterol do not help. Not for acute asthma attacks anyways. So if you want to treat acute asthma, you have to do the following. Nebulized albuterol, inhaled ipratropium, IV methylprednisolone, and you can consider IV magnesium. Okay? Everything I had mentioned earlier is more of a long-acting. Treatment for acute asthma, nebulized albuterol, inhaled ipratropium, IV methylprednisolone, and IV magnesium. There's no clear benefit of IV steroids over PO steroids. So, I don't know. What agent is more effective in treating asthma? Levalbuterol, also called Xopenex, or good old albuterol. What's more effective in treating asthma? Neither of those. So they both have the same efficacy. So Xopenex, which is called levalbuterol, is just the L isomer or whatever, and it's more expensive. So you can use good old albuterol, and it's just as effective.